Climate change has adversely affected the physical and mental health of people, and we have evidence from the IPCC 2023 reports. It contributes to incidence of illnesses, premature death, mental health threats, and food insecurity. And it's been documented that in excess of 250,000 deaths per year will be occurring by 2050 if we don't do anything about how climate change affects health and health systems. Health systems are increasingly exposed to climate-related hazards. And for this afternoon, we are going to look at climatic events such as floods, drought, extreme heat, and extreme cold. Here, we are going to focus on health service delivery, infrastructure, and our health workforce, how the climate change impacts on health workforce productivity. As already mentioned under the SOGI project, the climate change and health systems topic area here in Ghana focuses on the development of a globally generalizable framework for assessing the impact of extreme climatic events on healthcare systems. So though the work is done locally, it's actually a global framework that other countries can also use as well. And I must emphasize that this work is actually aligned with the Belém Health Action Plan, which is organized around measures aimed at addressing the urgent need for building resilience of health care systems to climate-related challenges. So in the Belém Health Action Plan for the adaptation of the health sector to climate change, it is clearly spelled out that the aim is to strengthen the health sector's adaptation and resilience to climate change by advancing integrated surveillance and monitoring, accelerating capacity building, promoting evidence-based policy implementation, and fostering innovation and sustainable production with justice and equity as cross-cutting principles. So our work actually fits in here. So what are the gaps that we try to look at? Previous studies and assessment highlight growing vulnerability, but focus mostly on the disease outcomes. And there is limited understanding of the indicators needed to measure causal pathways through which different climate events such as the heat, the extreme cold, floods, and droughts affect our health worker productivity, continuity and availability of essential health services, and infrastructure functionality and safety. Few studies actually have looked at this from using qualitative means that would come out with the context-specific measures on health workers and facilities used to maintain operation under climate stress using qualitative approaches. So what did we do in terms of conceptualizing the work or the research? We actually employed the WHO, that is the World Health Organization 2015 building blocks framework for health systems, which has 6 main blocks. And for us, we are looking at 3 out of the 6. We are looking at the health workforce, the service delivery, and infrastructure, which is also incorporated in the essential medical product and technology and infrastructure. So when you want to conceptualize this in terms of climate drivers, exposure and vulnerability, the impact pathways, the healthcare system outcomes, I will not want to read, but a lot of the drivers here, we have the floods from the rainfall, excessive rainfall, the droughts, the cold, extreme cold, and extreme heat affecting our healthcare system, which we are going to explore this afternoon. We have direct and indirect exposure of our health workers, our patients, infrastructure to these climatic events. And we go on to also explore about adaptation and mitigation measures and the outcomes on the healthcare system in total. So what are the objectives for this particular research? 2 main things. The whole work is borders on indicator development. So the objective one is to develop indicators to examine the pathways through which climate events influence health worker productivity, the continuity and quality of service delivery, and the functionality of health infrastructure. These are the three main building blocks out of the SILS that WHO framework looks at and which we are focusing on. And the second main objective is to explore the current and also the future adaptation strategies. So in terms of methodology, we are working through study design and participant selection, data collection, how we transcribe the data, it is the qualitative information, how we reduce the code, and how the thematic analysis was done. So the first one, qualitative study design, was employed. So here we are looking at methods like focus group discussion, key informant interview, and expert group consultations. In terms of focus group discussion, we had 18 across all the regions in Ghana, they were zoned for us to have a very good representation. 63 key informant interviews, and I must say that these were purposely sampled. And we use the word here, adaptive sampling, because we had to adjust as we move along. So in terms of data collection, we have the semi-structured interview guides to guide the data collection processes. And the very important thing here, I must say, is the targets, very much targeted. We engage with regional health directors, we engage with health promotion officers, health information officers, community-based health planning and services coordinators. We also engage with public health officers, as well as public health nurses and facility users. I must emphasize on the facility users. So to capture the on-the-ground issues, how people experience the climatic events impact on health systems. And then we did a transcription using a hybrid coding in Max DA, both deductive and also inductive insight into the codes that we developed. Here we had about 5,000 plus basic codes, but then we needed to reduce to be able to analyze. So that is where we have the code reduction and review processes. These are internal synthesis merged with where duplicates are merged and overlaps are also taken care of. After doing that, we had expert-informed refinement of the process. We have developed a code book for all the processes. We had 2 peer debriefing rounds to test the coherence of the themes that were being generated. We have applied multi-criteria decision-making to weight key pathways and maintain analytical traceability and methodological transparency as well. I must say that in terms of thematic analysis, we use the Sterling's framework, where we have the basic codes, we organize them, and then we have global themes. So a lot of our findings go through these motions, and then we focus much on the few global themes and what the implications are for indicators and how the indicators can be explained. So these themes are aligned with the indicators, and I repeat, we have indicators on health workforce productivity, service delivery, and also the infrastructure loss and damage. So these are the 3 main pillars out of the WHO building blocks that we are looking at. So now findings. What are the impacts of climatic events on health worker productivity? So here we have them in 4 blocks: the impact of excessive rainfall, impact of heat on the health systems, impact of extreme cold, and impact of drought on the system, the health care system. So for rainfall or excessive rainfall, we have, or floods, we have destructive routine services of our health workforce, missed target and performance pressures during floods, occupational hazards and safety risks, cuts to access to facilities and communities, and there were also logistics losses and operational delays. For rainfall or floods impact on the health system, health workforce productivity. For heat, we have physical fatigue sleep disruptions, patient surge at the clinic or the facilities, mental health strain, and health risks on our healthcare workforce. When it comes to cold, we have illness, burden, fog-related travel risks, workforce strain, work disruptions, absenteeism. And when it comes to drought, we have mainly water scarcity, undermining facility hygiene, psychological strain on our health workforce, health challenges, and physical exhaustion from water scarcity, and workload surge from crisis. And all of these are impacting on health workforce productivity. Now, when it comes to infrastructure, we have medical storage infrastructure, the supply and operational cost, building and health logistics, health information system. These are the classes that you could have. So let me pick just on the medical storage infrastructure. We have in detailed inadequate temperature control system for medicine safety, heat undermining medicine storage, extreme temperatures, overwhelming existing cooling infrastructure, flood damage to refrigeration units. I'm not going to read through all, so we could have a lot of time for engaging with our audience. But let me pick on the building and health logistics and the infrastructure, non-adherence to building standards, structural collapse due to rain, transport barriers to supply delivery, supply chain disruptions from increased patient load, increased pressure on social amenities. I must say that when you look at the details, how these indicators are framed by our health workers that we interacted with, you could see a lot of linkages. But for today, we are just looking at them under each of the indicators. But then you could have linkages when you put them through another iteration of analysis. So for service delivery, the impact on service delivery, we have disruption to routine service, instability in service provision, health breaks and mortality, access disruption due to floods, also disruption to health logistics and supply chains. Now, so we also try to come out with some indicators to how the existing adaptation strategies to actually focusing on the health worker productivity. How are they adapting? How are workforce adapting to this situation? So here again, we have organized them along themes. We have human resources and health staff capacity, preparedness, planning and protocols, emergency teams and structures, community engagement and adaptation actions, access of healthcare workers to disaster risk management training. So I will pick one after the other, the codes that came through. So basically, how do you describe the details into the human resource and health staff capacity? So here we are looking at availability of skilled health staff, climate-focused training for health staff, pre-seasonal staff sensitization on health risks and climate-sensitive diseases. In terms of preparedness, ongoing preparedness plan updates, simulation drills for emergency preparedness, protocols for escalation and emergency support channels. In terms of emergency teams and structures, we have public health emergency committees, rapid response teams, facility level emergency teams, risk communication teams. These are all the strategies that are actually existing currently to handle the effects or the impact of a climatic event on health worker productivity. We know that when it comes to productivity, you can best define it by looking at the output and inputs. But for this particular work, we try to capture the unmeasured, the things that are difficult to measure. And they could just be described by the engaging with the health workers and also the facility users themselves. So we have to keep this in mind. It's a qualitative study, and the codes were just so many, and we needed to drill it down. So we had to go through the methodology that we went through. So continuing with the key findings for infrastructure adaptation to impact on the infrastructure. Here again, we have clustered them into health information and data continuity, facility cooling and comfort. We have infrastructure maintenance and resilience, power, energy and cold chain continuity, water supply security, climate resilient infrastructure, standard emergency medical responses and preparedness, and community and local support networks. So let me start with the local support networks. We have community-based emergency systems, community transport, and basic repairs to overcome the effect of climate change on the infrastructure coming through from the community level. Then we have emergency response systems, climate-sensitive disease preparedness, public health education and training for emergency medical response and preparedness team. For infrastructure, climate resilience infrastructure standard, we have climate resilience upgrades, green energy policy engagement, and also when you pick on power, energy, and cold chain continuity, we have to have backup power and cold chain continuity systems, solar lightning solutions. Here we are talking about green solutions, connectivity and communication continuity. We need to keep an eye on that because without connectivity, a lot of things would go wrong, especially with our health information and data continuity systems. So speaking about health information and data continuity, data backups are very much ideal in these situations. National and facility level digital systems, GIS and community-based reporting tools, remote and offline data access. These are all things that are being done in terms of adaptation to hold the effect of the climatic event on infrastructure. So for service delivery, what did we come up with? We have water supply and storage systems, renewable and backup power supply and equipment protection, cooling and heat management, flood safety equipment, and community and partner engagement. So these are some adaptation systems that we were able to capture. So in terms of future priorities and future adaptation, what are we looking at? So in terms of future adaptation for health workforce, a lot of things should go on into preparing health facilities to manage climatic events, also improving the disaster risk management system that we have in place, improving experience with disaster risk management training. So let me just speak on preparing health facilities to manage climatic events. The basic goals here, climatic inclusive emergency planning that focuses on climate integrated health training, proactive workforce deployment, climate resilience infrastructure, climate disease management capacity built. We need to institutionalize our disaster risk management system, especially keeping an eye on the climate change impact within the healthcare system. We need to have a critical look at how equitable access to these systems are across board. We need to look at issues of inclusion of disaster preparedness in formal curriculum, that is in terms of training, cascading training to all healthcare staffs at all levels, regular training intervals, integration of climate and One Health in training, and also training on safe zones and evacuation mapping. So when it comes to improving ability to provide services during climatic events, that is under service delivery, these are the basic goals that we came up with: climate-ready facility design, equitable and supported workforce, disaster resilient service delivery, emergency preparedness systems, reliable logistics and supplies moving into the future. Then also when it comes to infrastructure, we are looking at infrastructure, retrofitting and facility location, equipment protection and heat response plans, logistics and supplies for emergency preparedness, energy and water system for climate resilience, ventilation and cooling improvement systems. Yes, so after going through all these, what are the policy recommendations? First of all, we need to recognize the climate change as a systemic health risk in national health policy. A lot of the policies that we actually reviewed did not keep an eye on climate change effect on health systems, and this will have to be re-emphasized. We need to incorporate climate health indicators into our national data system. The indicators that we have developed, we have already started engaging our national data system holders for us to integrate this work, integrate climate risk standards into health infrastructure planning, incorporate climate resilience into workforce standards and occupational safety, as well as capacity building. We need to mandate climate resilient facility design and expand digital monitoring. Embed community and frontline on practical knowledge into policy and planning. There are certain things that you cannot get from quantitative study. You need to do the qualitative to get the frontline and practical knowledge to be able to capture that and embed in our planning systems. So in conclusions, first of all, climate change is a systemic stressor that fundamentally reshapes workforce performance, service continuity, and infrastructure functionality. There is research evidence showing the relevance of capturing the unmeasured health system. That is exactly what we have done. The unmeasured health system indicators. And this is significant for consideration toward the implementation of the Belém Health Action Plan. Ghana's health system is adaptive but uneven. We say Ghana because the work was done here, but these are contextual realities. The work has a global standard, but the contextual realities are also very important. So with resilience that remains largely reactive, fragmented, and under-resourced. Current adaptation depends heavily on individual and community improvisation rather than institutional preparedness, and this is what we need to correct. The main barriers are structural, including weak governance, centralized decision-making, and inadequate climate-specific financing. Though we did not cover financing, it came up very much in the discussion, the adaptation, around adaptation, current and both current and future. So future adaptation requires system-wide integration of climate preparedness into workforce training, service delivery, infrastructure planning, and financing. The solutions are known, but under-implemented, and progress depends on sustained investment, decentralized financing, and leadership accountability. So what are the implications for meeting the Belém Health Action Plan? We need to define responsible units and budget lines, as well as deliverable across the four main pillars, including an equity lens and civil society participation, involvement, aligning our proposed indicators with Belém at target 9C categories, where we emphasize on health impacts, health system resilience, and population exposure. Adopt the WHO climate resilience and low carbon facility, which is a WHO 2023 norms in capital planning for all new buildings and retrofits. Undertake pilots looking at our solar refrigeration, basically looking at green systems, microgrids, heat alert systems with operations research to generate the evidence for prioritization of the Belém Health Action Plan. So with this, I come to the end of our engagement. I hope you have enjoyed our presentations and we stand by to engage and have more discussions on the presentations. Thank you.